I'd like to introduce our first speaker. So it's Dr. Vladko Bakowsky. So Dr. Bakowsky is a rheumatologist and presently the interim head for the Division of Rheumatology and an associate professor in the Department of Medicine through Dalhousie University and QE2 Health Sciences Center. Apologies. He will be speaking today about arthritis and treatments. So with a warm welcome, I'd ask you to please welcome Dr. Bakowsky.
Good morning, everybody. Whoa, feel like a school teacher or preacher or something. So anyways, I have two last names. My first name sounds like a last name too, so if you're wondering about that. And when I give a talk, it's usually all about the title. I find some really snazzy title, and it distracts people from realizing that I'm not actually saying anything of substance. So they're just thinking, that was a great title, you know. So anyways, so the title, you know, obviously pills, right? I'm a pill pusher. That's what I do. That's my business. Then there's also potions, right? So this is apple cider vinegar, and that's supposed to be good for arthritis too, right? So maybe we should be taking potions. And then poultice, that's kind of maybe only older people remember what a poultice is, but basically people would grind up herbs and other vegetable kind of matter, and then they would put a gauze on it and put it over whatever was sore. So that's where the title comes from, pills, potions, or poultices. What's the best treatment for arthritis? Now this is very topical because this was in the news, my beloved Montreal Canadiens, who lost again in overtime. But in any event, one of their star players, Brendan Gallagher, he's been putting this sort of German cream that he calls pickle juice because it's green. It's got all sorts of herbs in it. He's been putting that all over his legs before games, right? So, I mean, if it's good enough for a multi-million-dollar hockey player, maybe we need to find out what this pickle juice is and rub it on ourselves. So, you know, the term arthritis, the Arthritis Society used to say there are over 100 types of arthritis. And I don't think they say that anymore, and I'm glad because I don't think I know 100 types of arthritis, and I'd worry I was put on the spot that I'd have to name them sometime. But oftentimes, you know, when people have pain, any kind of pain gets lumped in with arthritis, but there are things like, you know, sciatica, which is really a pinched nerve, and it's not really arthritis. Or if you have tennis elbow, that's a tendon problem. That's not really arthritis either. So a lot of things get lumped in with arthritis that maybe aren't necessarily arthritis, and that adds to the confusion. So the term arthritis comes from the Greek word arthron, which means joint. So arthritis is, you know, inflammation of the joint. But there's also this other term, arthropod. So arthro also means joint, and pod means foot. So this means, you know, a joint or foot joints, I guess. So this is a little bug. This is called a pseudo scorpion, and I've actually seen them in our house. And so that reminds me, does anybody want to buy a house? I thought of moving out. It's pretty fearsome. They're pretty harmless, but in any event, you could see that they have little joints here, you know. Well, I'm way far away, but anyways. So that's where the term arthropod comes from. See, I teach you useless things that you'll remember, and then the important there really aren't any important things, let's face it. So then, you know, I'm a rheumatologist, and I used to joke around, even my mother didn't know what a rheumatologist is. But it's, you know, a member of the healthcare team that can help people with arthritis. Now, gradually over time, we've morphed into, we really focus on inflammatory types of arthritis, and we really haven't focused on osteoarthritis, mainly because there's, unfortunately, as you'll see, there's a huge gap and unmet need in the medical treatment of osteoarthritis. So we tend to focus on inflammatory types of arthritis. Now it comes, rheum means flow, so these Greeks are everywhere, and there were these 4 humors in the body, and if there was an interruption in flow of one of these humors, it caused disease. So that's where rheumatologist comes from. We really need to update our name but we're kind of stuck with it for the time being. Now, if you actually Google rheum, that's actually a word. It's the kind of the watery, kind of mucousy discharge from your eye or your nose. And so this kitty cat has this, I can't really point. Anyway, so you can see the goop in the corner of his eye, that's rheum. So basically, I'm that kind of doctor. I treat eye goop. And I have a disclosure to make. This is really captured in this cartoon. Your fear, this guy's seeing a psychiatrist or psychologist, your fear of being publicly exposed as a fraud is a stress-related disorder called imposter syndrome. It's common among people in high-profile authority positions and, of course, in actual phonies like you. So I'm either a phony or I have imposter syndrome. I don't really know. So, as I mentioned, arthritis is really kind of diseases of the joints, and they can be divided into non-inflammatory conditions. And we say, oh, your joints are wearing out, or it's degenerative, or something like that. But that's really synonymous with osteoarthritis, which I think most of you have blue stickers. I was hoping that was, blue states or something. But no, it means you have osteoarthritis. And we call it non-inflammatory, but it's really mildly inflammatory. It's probably overstatement to say it's non-inflammatory. People can get warmth in their joints, they can get a little bit of swelling, but it's not as inflammatory as inflammatory arthritis. There's more swelling, more warmth, and stiffness really that can last hours. There's some people, they ask for an appointment in the afternoon because if they have to come in the morning, they have to get up at like 4 or 3 in the morning just to loosen up enough to come to see me. So that's kind of the broad division, inflammatory versus non-inflammatory. And here's just a picture of a normal joint. So basically you have a bone here, say that's your thigh bone, this is your shin bone, and then you have a capsule, so you've got this kind of skin around your joint it's really only normally a couple cells thick, it's very thin. It secretes a little bit of fluid to make the joint run without friction. And sometimes you have things inside your joint like these are your little cartilage bits here. Those are your menisci, extra bits of cartilage that help provide stability. So that's sort of what a normal joint looks like. And of course you have cartilage on either side of the joint that helps the joint run frictionless without pain, etc. So here's a slide of a tissue of a joint. It's obviously small, it's probably a finger or a toe. But it's really beautiful. See, I don't get out much, so I think things like this are beautiful. But, oops, now so this here is your bone. This is your cartilage cap. And over here is your joint capsule. So you can see it's like polished porcelain. It's just, you can just see how perfect it is when the joint is healthy, that things can move without any pain and without any bother or stiffness. So in osteoarthritis, what tends to happen is the cartilage gets broken down, and your body's trying to build some of it back up again, but it gets broken down faster than it can get built up, and you kind of lose cartilage, and it's patchy. It's not uniform through the whole joint. And the bone on either side of the joint, it's almost like it's trying to splint the joint or an abnormal repair process, but you get these bony growths on the edge of joints. And that's why people with osteoarthritis would have knobby knuckles, for example. So the lining of the joint, it's thickened compared to the normal joint, but it's not super thickened. And here's a same sort of slide. You cut through a joint. You can see that the cartilage, there it's nice and healthy, but here it's kind of disappearing. You can see that this bony growth right there, that's that osteophyte that I mentioned. And there's not a ton of inflammation through that joint capsule. And here's a classic picture of somebody with osteoarthritis in their knuckles. So they look swollen, but if you actually feel them, they're hard like almonds, and it's actually bone that you're feeling. So in any event. And here's an X-ray of somebody with osteoarthritis. You can see this is the thigh bone, this is the shin bone, and over here, like that is the joint space here, and over here the joint space is completely gone. So that's when people say, oh, you have bone on bone, and that's very painful because in cartilage there are no pain fibers in cartilage, but there's pain fibers in the skin that wraps around bone, and so when bone is grinding on bone without any cushion, it's very painful. And here's a picture of a knee at the time of replacement. You can see that there's, it's very patchy. Like over here, the cartilage isn't so bad, but over here, it's eroded, and you're seeing that pink tissue is the underlying bone. So now inflammatory arthritis is a broad category, and it can be infectious. Like you could get a bad bacterial infection in your joint, which is an emergency. You need surgery right away. You need antibiotics right away. There are also chronic infections that can cause arthritis, like Lyme disease, which is very topical these days. You can have arthritis from crystals. So gout is the most common one, but there's another crystal the lay people will call pseudo-gout, and that can cause an arthritis. And then there's rheumatoid arthritis, which either some of you have or most of you know about. There's another group called Spondyloarthritis, which is a terrible name because it means spinal arthritis, but you don't have to have spinal arthritis to have spondyloarthritis. So people almost have to try to make it this confusing because it just couldn't be random or something, right? But in any event, spondyloarthritis is a group of diseases, including psoriatic arthritis, ankylosing spondylitis, and we kind of lump them together because they're more similar than they are different. And then there is always the other category, things like polymyalgia rheumatica or PMR, things like lupus, for example. So that's sort of a broad overview of the subtypes of inflammatory arthritis. So in an image of inflammatory arthritis, generally what you're going to see is that the joint lining is very, very inflamed, very thickened, and sometimes it secretes, all that inflammation. Just think when your nose is runny because you have a cold, all that liquid and goop and mucus that's being generated in the inflammatory response. Think of that occurring in your joints. So they can be quite swollen. That lining of the joint, which is normally just a few cells thick, is very, very thick because it's infiltrated by fibrous tissue, vascular tissue, and inflammatory cells. And the inflammation tends to eat into the bone. So you get these, it's almost like a mouse has been nibbling on the corners here. We call those erosions. And the cartilage, it tends to be completely gone. So the picture is not completely accurate. It tends to be more evenly worn out than in osteoarthritis. And I'll show you a picture, and this is of a tissue from a joint that's affected by rheumatoid arthritis, and it's hard to even know what you're looking at. I mean, this here is, oops, I'll keep pressing the wrong button. That here is bone, and then all this goop, that's all kind of proliferating joint lining, and you can't really, you almost, the architecture in the other slides where, you could clearly see bone, you could clearly see the cartilage, in that instance, it's all just infiltrating inflammatory mass, basically. So I'll just show you a couple slides on gout. So gout, the treatment is really, really good. We basically cure gout with medication. So probably if you have gout, you don't come here on a Saturday morning because you're at home cured. But people often wonder what it's like. Oftentimes it very quickly affects a joint. So people go to bed, they wake up, and their joint is really sore. And characteristically, it likes the big toe. And the inflammation is very intense. It can cause redness of the skin, which usually rheumatoid won't, and sometimes even the skin peels off. The inflammation is so intense. And gout can become chronic too. And these are all, this person was sent to me for psoriatic arthritis because they do have psoriasis, but all these lumps are all sort of gouty crystal deposits in the hands. So, this really shouldn't happen because we do have good treatment for gout. So gout too can become chronic sometimes. And this is what the gout crystals look like under a microscope. So they're either, we use a polarizing light, and they're either yellow or blue. And if you dug into one of those lumps in that person, it would come out looking like chalk. And if you smear that on a slide, it looks like that, which is kind of pretty. And it kind of reminds me of modern art, right? That's a Jackson Pollock, which I think probably most of you are thinking I could paint that. I think I could, and I have no talent. So in any event, so just a bit about gout. So rheumatoid arthritis, it can affect many joints, and you can almost more appropriately say all of them with certain exceptions. So it doesn't affect the DIP joints, the distal joints in your fingers, and it doesn't affect the spine other than the neck. So the rest of the spine it leaves alone, but really it can affect almost any other joint in the body. And when I teach people, I say this is the pattern of everywhere a joint, and I'll get back to it. So I just try to have them remember that, everywhere a joint. So in addition to affecting your joints, rheumatoid arthritis sometimes has extra-articular features, so features outside the joint. And they would include things like rheumatoid nodules. People get these lumps often on their elbows. Sometimes they're on the palms, sometimes they're on the soles. And these poor people, they have to, they're walking like they have a marble. You know how when you had children and, the room was dark and you're walking along and bam, you get the piece of Lego in the foot. I'm not sure if you remember those days. That's how they step every day because they've got a lump on their foot. So anyways, it can affect the eyes as well with dry eyes or an inflammation called scleritis. And also it can affect the lungs, and that can be a very serious problem of lung fibrosis. So it's a systemic disease, not just your joints. And here's a picture of somebody with rheumatoid arthritis. You can kind of appreciate that these knuckles here are kind of puffy, and if you press on them, they're squishy like a grape, whereas in osteoarthritis, they're hard like an almond. And probably these ones are puffy too, right? So that's somebody with early rheumatoid arthritis. And of course, we want to prevent things like this from happening. So long-term disease, that long-term inflammation can damage the cartilage. It can result in ligamentous disruption, and you can get deformities in your hands and elsewhere, right? Or damaged joints that need surgery. So this is kind of what we're hoping to avoid in patients with rheumatoid arthritis. So that other group of diseases, spondyloarthritis, which I said is a terrible name because you don't necessarily have to have spinal arthritis. Its pattern is more typical this. So it tends to be, a joint like it's in, I think I'd learned by now. So for example, it's in one knee, it's in the opposite ankle. It can affect a finger, and if it affects a finger or toe, it's often the whole digit, whereas rheumatoid tends to spread laterally. This type of arthritis tends to spread distally. And the spine can be involved in this disease as well. So I call this pattern the here a joint, there a joint, versus the everywhere a joint. And the students sometimes remember that. So the classical thinking was that we had all these separate diseases and they were included in a broader category, but now we kind of lump them together for the most part, differentiating whether they have spinal involvement or whether they have peripheral joint or both. But it can be associated with things like inflammatory bowel disease. It could be associated with salmonella infection. And then, of course, there's always a none of the above category. So these, the spondyloarthritis group, the things that they share in common are that the whole finger or the whole toe can be involved. We call that dactylitis or sausage digit because it looks like a sausage that you've just put on the barbecue and it plumps up, and now you'll never want to have a sausage again. But it also can affect the DIP joints, these ones, which so you have to sometimes sort out, is it osteoarthritis or is it this type? Because they're the two that affect the distal knuckle. Enthesitis means where inflammation where tendons and ligaments attach to bone. So very often they have, Achilles tendonitis or plantar fasciitis, which is pain on the bottom of the heel. And as I mentioned, they can have spinal involvement. They also get a characteristic eye inflammation called uveitis. And it's associated with this genetic test, HLA-B27. So about 90 to 95% of people with spinal involvement from this disease carry that genetic marker. And here's an image of somebody with a spondyloarthritis pattern. So if we look at a few things, this middle finger, the whole finger looks big, doesn't it? And so the whole finger is inflamed, and it's also shortened. So one of the features of this type of arthritis, it can cause bone resorption. And if you look at the poor pinky fingers, they're really short there. So, and you can also see that the DIP joint is involved. But, other fingers might be relatively spared, like this index finger here, which is unusual in rheumatoid. Usually it would affect all of them. Although some reason the ring finger is sometimes spared. It's kind of strange, but, and it's not just the one side, so we can't say it's the wedding ring. It's, and if somebody has spinal involvement, their spine gets very stiff, and you can see this individual when he's bending, all the bending is happening at the hips. His back isn't curving at all. So in general, the treatment of arthritis, things like today, education are important. I think exercise is a very big management strategy for arthritis. I'd say exercise is a drug and we all need to be on it, and I'm glad they're prioritizing and emphasizing it today. So chronic disease management, by that I mean, if you have a chronic disease, it's in your interest to be as healthy in every other way possible. So try to keep near your ideal body weight, try to get enough rest, try to eat healthy. It just makes sense. That's not to say if you remove, tomatoes from your diet, everything's going to be good. But I think, just in general, eating a healthy diet is a good idea. Local therapy are things like, heat and ice, and people ask me that all the time. It's whatever makes you feel better. If you like ice, fill your boots. If you like heat, fill your boots. One isn't necessarily better than the other. And physiotherapy has a role, occupational therapy, different aids, right? If you have a bad knee, you should have a cane in the opposite hand. You might benefit from splints if your wrists are really damaged. You might benefit from a knee brace if you're trying to delay surgery, for example. So medications are kind of down there after all those things. And I'll talk a bit more about medications because that's what I do. Now surgery is kind of, the salvage procedure, but it's often, amazing, right? Like I'm slogging away through life trying to help people, and then somebody has an operation. They're forever grateful. Their face lights up when they, mention the surgeon's name, right? Sometimes they have this very brief interaction, but they really help people a lot. And for osteoarthritis, that is the main management. At the end of the day, people are going to need surgery. And so they've made tremendous gains. And so surgeons tend to be, fairly big egos. And I don't think this is not news, is it? No good. So, and they often don't get along either. But they voted on the best surgery of all time, and the hip replacement won. And so it beat things like open heart surgery for ischemia. So the surgeons who never get along all voted, and that's what they voted. And it really can be, it's not perfect. Not everybody has amazing result, but in general, it's a godsend for people with an end-stage joint. And Dr. Dunbar, one of the surgeons here, he says the hip joint, he says you could put the damn thing in backwards and people would still be happy. So I think the hip is like the best one ever. I'm sure he never does that. Certainly not on purpose, but other surgeries like the knee aren't quite as good as the hip, and then upper extremity, shoulder, elbow. The hip is, I think, the ultimate joint replacement. But in any event, so I shout out to my surgical colleagues that they have made great advances for osteoarthritis or end-stage joints that the medical types really haven't. Don't tell them I said that, though. So as far as drugs, and I've put, pharmacologic, even though our nutritional supplements, are those pharmacologic or not? I mean, anything you swallow, I think, is kind of a drug, I think. And so people, often take nutritional supplements for osteoarthritis, shark cartilage, glucosamine, then acetaminophen is obviously very common. Anti-inflammatories could be oral or topical. So topical is nice because it's safer. It's not going to cause your stomach to bleed. It's not going to. But if you have 20 painful joints, you can't, take a bath in topical NSAIDs really. And then there's opioids. And opioids, you can't read the newspaper ever anymore without seeing a story about opioids. And I think opioids were overused, and now they're probably underused because everybody's so afraid of prescribing them and whatnot. So in the world, the pendulum swings, right? And I think we're in a swing where it's maybe going to go back a little bit at some point. There are corticosteroid injections, which tend to be short-lived benefit. So if you have a disease that you're going to have for years, if you get a 2 or 3 month benefit, I wonder whether that's worth it. The patients clearly will tell me whether it's worth it. I'll say something like, well, you only got 2 months relief. There's no point in their begging me for it because they're in pain and I'm not. So to them, it's worth it. And viscosupplementation, that was done more years ago. There are these things like Synvisc and whatnot they would inject into knees, and I think there are still some orthopedic surgeons, I think, that do it sometimes, but it's generally fallen out of favor for not being all that effective. So that's, in osteoarthritis, there's no medication that slows down the process or prevents the deterioration from happening. So it's hard for people to believe that because you read the paper and there's all these advances, there's stem cells, there's this, there's that. But for something that we're all going to get if we live long enough, there's, the acetaminophen, the anti-inflammatory, they're just pain relievers. They don't modify the history of the disease. They don't fix something. They just help make people feel better, which is obviously important, but you'd really like to have something preventative, I would. So, glucosamine and chondroitin sulfate, I think, there was a time everybody was on it, and I think now a few people less than everybody are on it. It seems to be not as popular as it once was. And there was a study done by the National Institutes of Health, and that's kind of, if you're a physician, that's what we think of as like the ultimate, holy site of medicine is the National Institutes of Health. In any event, they did a study looking at treating OA with glucosamine, chondroitin, the combination of the two, or celecoxib. And if you look at the patient response at 24 weeks, first of all, so this bar here, the first one is placebo. So that was just a sugar pill. And you can see that like 55% of patients got better with the placebo. And then if you're looking at, these are the group that were given, glucosamine, chondroitin, and the combination, and they weren't significantly different than placebo. The only one that was statistically significantly better than placebo was the anti-inflammatory celecoxib. So what do I take from this study? Well, I take from this study that the mind has a tremendous influence on pain. And so, if you're in this study, you're getting attention and you're taking something that you might think that works, like half of the people get better. And I also took that the glucosamine, et cetera, didn't seem to be all that much different than placebo. And then if you look at celecoxib, the difference between celecoxib and placebo is only 10%. More got better. So I think, people who take celecoxib, they feel better. A lot of that is probably placebo effect. And it comes at a cost of, the price of the drug and potential side effects of the drug. So I think anti-inflammatories are effective, but they're actually only minimally more effective than something like a sugar pill, right? So in any event, it's a little bit depressing, but so in order to raise our spirits from that fit of depression, there was another study that looked at the effect of diet, exercise, or the combination of the two, versus just saying, you should lead a healthy lifestyle, which is what I did earlier. So this WOMAC function, it's a outcome measure in osteoarthritis studies, but you can see, the people, oops, I keep doing this. The rats, where this is. So this is, healthy lifestyle. The lower the score, the better. Healthy lifestyle, then you see, exercise got more benefit than just lead a healthy lifestyle. Diet had a more substantial effect, and diet and exercise did the best. And 30% of the people in the diet and exercise group had a 50% or more reduction in pain. So I think when we talk about, the importance of exercise, the importance of diet, there's actually, medical evidence to suggest that that's actually a good thing, right? And people with osteoarthritis, when you do things, it often hurts. And so people are worried they're going to damage their joints, they're going to make them wear out faster. But, cartilage, it doesn't have a blood supply. So when you load it, you squeeze out a little bit of fluid that's in the cartilage, and then when you release that weight, it sucks up some of that fluid. So that's partly how cartilage gets nutrition. And plus there's a million reasons why exercise is good. It's good for the head, helps you sleep, helps your mood, etc. It's a drug. So when I went through that list, there's nothing tremendously, mind-blowing that I can take for my osteoarthritis when I get it. And so there's a huge unmet need, right? Anti-inflammatories don't work all that well. Acetaminophen doesn't work all that well. No one will give you opioids. And so in that vacuum of unmet need, there's now, this, right? And so for those of you that lead a sheltered life, that's marijuana. And really kind of the medical community, we've been sort of pulled here by people, right? The people have said this is what we want, and we didn't sort of direct it, and we're kind of late to the game, and so I think we've kind of failed the public in that respect, right? We kind of keep thinking somebody else is going to do this or something. So, I think it's completely, totally in fashion. Everybody wants to talk to me about it, and I don't really know exactly what to say. I used to say, why don't you get it from a friend of a friend of a friend, like the rest of the people, right? But it's now legal. It's you can buy it in the liquor store. But there are various compounds, like they separate the THC, which has some of the sedating effects and the high effects. And they separate out the cannabidiol, which is supposed to be the pain relievers. And I think this speaks to the fact that there's so few great alternatives that there's an unmet need and people are searching for something, right? Now, this is a website called PubMed. And if you ever want to irritate your doctor, just say that you've searched something on PubMed, because it's our own damn website. And so if you find something, we can't say, well, that's our website, we're stuck. So in any event, this is how we search for studies and information. And so I just punched in osteoarthritis and medicinal marijuana clinical trial, and I got 0 items. So then I put in osteoarthritis and cannabis, and I got 0. So no matter how I massaged it, I got 0. So there's not a great deal of evidence for it. It's kind of very, very popular and very topical, and it kind of speaks to the fact that we're just not doing a good enough job already. And but I think we also need to do a better job of just sorting this out ourselves. So and this I Googled osteoarthritis cure, and I think I got 14,200,000,000 hits. And so I mean, if there was a cure, there'd be probably fewer hits because people just go and get the cure type of thing, right? Again, this speaks to the unmet need that we're facing here. And there's a book, The Arthritis Cure. There's various ointments. There's a lot of stuff. So, as far as treating RA and spondyloarthritis, we have made substantial advances there. And they're not all the same, they're not the same disease, and some treatments work for spondyloarthritis but don't work for RA and vice versa. And then even within spondyloarthritis, the treatments vary whether or not you have spinal disease. And you often have to account for what kind of comorbidity the patient has. It can affect and guide what treatment you use. For example, if you have Crohn's disease or ulcerative colitis, then we would steer toward therapy that works for ulcerative colitis and Crohn's disease or works for psoriasis. And in general, we try to treat to a target. So we try to, one target is the patient happy? That's a nice target. But in addition, is the disease in a low disease activity state? Because if there's uncontrolled or inflammation, then the joints can be gradually damaged. So we try to treat to a target. So for these diseases, again, exercise is important. And anti-inflammatories often are good pain relievers for people with inflamed joints. And we do use corticosteroids, even though they have lots of potential side effects. And either we inject them into joints or give them systemically. But none of these things probably alter the natural history of the disease. But fortunately, we have things called disease-modifying anti-rheumatic drugs. And these do alter the natural history of the disease. They prevent joint damage, they reduce disability. And these ones are the traditional ones. And it's embarrassing to say, but we really don't know how most of them work. And even things like gold, we still use gold, believe it or not. And it came from when people thought syphilis caused rheumatoid arthritis, and they were treating syphilis with gold. And the syphilis didn't get better with gold, but actually, by serendipity, rheumatoid arthritis did. And we often do use these drugs in combinations. If the first drug doesn't work, we add on, just like if you have high blood pressure and your blood pressure isn't controlled. Some people need 2 drugs, some people need 3 drugs to control their blood pressure. So those are the traditional medications, and they tend to be less expensive. They tend to be tried first. So this slide shows you, immune cells, right? And they communicate to each other with these chemicals called cytokines. And, it's really complicated. Like, I honestly don't know this. My brain could not remember this all. And then, every year we discover more and more of these messengers. So eventually it's going to be like this, neural network or something, how these cells and how your immune system interacts. Because your immune system's there to defend you against things that aren't you, like bugs and viruses. And in autoimmune disease, what happens is you lose tolerance, and what happens is you start recognizing parts of your body as being foreign, and that triggers the inflammation. So there's so much overlap, it would make you think there's no point in blocking just one messenger. Like if you block that, you have all these other pathways. And so if they would have asked me, I would have said, don't bother, it's not going to work. However, they didn't ask me, and thankfully, because it actually does work. So you can block just one of those messages, and you can have an effect. So one type of targeted therapy are known as biologics. So if you have an immune cell, it secretes this little messenger, this red thing, and it can diffuse across the space, and it can bind to a receptor here. That's like if this is a key, that's a lock, and when the lock goes in the key, the key goes in the lock, it stimulates that cell. So if you have a biologic, what you do is you interrupt that pathway. So what you do is you use a protein that acts like a drug, and what it does is it mops up that cytokine so that it can't get into it can't cross the space and bind to that receptor and interrupt that cell. So you can imagine if your teenagers are trying to organize a party and they're on whatever Snapchat or something, that's how 400 people can show up for the party all at once. But if you take away their cell phones, they're going to have trouble making that party. So that's sort of how biologics work. So the pros of the targeted therapy is that they're effective, and they often work rapidly, and generally they're well tolerated. The cons, the biggest one is the cost. I mean, they're thousands of dollars a year, And how we're going to pay for this all, I don't really know. They're generally given by injection, so people don't kind of bristle at the thought of an injection. And they are sort of more powerful immunosuppressants, so things like infections are a bigger problem. So I went into rheumatology partly because I didn't have to remember a lot of drugs. There was like only 5. And then this happens. Like we've got all these different ones, and so they all have, there are new oral ones. Jak inhibitors are targeted. They basically affect a receptor known as Jak, which is interesting. It's called Jak because it was first named after just another kinase. So some scientists have a sense of humor. But in any event, there's an awful lot of these, and they all have certain nuances and whatnot. There is a rhyme or reason for the naming, but I think I'll just skip that because I just want to leave that a bit extra time for questions. But from the name, you can tell how much mouse protein is in the antibody, and so you can just determine how much more you're going to like cheese after you take the drug compared to what you were like before. But in any event, and some of those earlier biologics, they now are sold as biosimilars. So biosimilar is a term, it's like generic, the patent has expired, but they don't call them generics, they call them biosimilars because they're not exact, they're similar. Just like this person and me, we're not identical, but we're kind of similar. And the benefit of those is they're driving the price of everything down, so that's good. And they're equally good. You're not getting a raw deal if you get one of the biosimilar biologics. So in summary, there are different types of arthritis, and the specific diagnosis guides therapy. I tell people if you get the diagnosis wrong, you could do everything else perfectly, but you still get 0 on the test, right? You don't get 9 out of 10 on the test. And there is, unfortunately, a huge unmet need in the medical management of osteoarthritis and pain in general. I think we're doing far better now treating inflammatory arthritis than we were when I was a resident. And I think, this is what my old mommy taught me. If something sounds too good to be true, it probably isn't. I think that applies to everything in life, really. So with that, I will finish up, and if you have questions, I'd be happy to take them. Just don't make them too hard.